out to the recording in a few days. So our speaker today is Dr. C. Chen. She is with the UF Health ENT and allergy practice located in the Oaks Mall. We also have our audiology clinic that's located there as well. Dr. Chen received her medical degree at NYU School of Medicine. She completed a residency in otolaryngology at the University of Miami. And then she also went on to complete a fellowship in neuro-otology at UCLA. She joined UF Health in 2019. If you have any questions for our speaker today, please don't hesitate to ask them. At the bottom of your screen also, there's a section called Q&A. You can click that button right there and type your question to me. Those questions come to me. I will then take those questions at the end of the talk and read those questions aloud. I won't say your name or share any information about you. I'll just read your question. So again, if you'd like to turn on your closed captions, if you need those on the screen, please feel free to do so. It's at the bottom on the right-hand side, and it's labeled CC or possibly more, and then hit the show full transcript. If you'd like to ask questions, again, use the Q&A button at the bottom of the screen. Dr. Chen, I'm going to go ahead and turn over to you now. Thank you so much.
Thank you, Marcia, for your introduction, and thank you for having me on the Wellness University at UF Health. So my name is C. Chen. Good morning to everyone. I am one of the otolaryngologists, or ENT, specializing in ear and hearing disorders. And neurotology, if you're not familiar, is pertaining to any skull-based disorders between the ear and the brain. So today our topic is hear better and stay well. What we want to do is to discuss with you the impact of hearing loss on your general health. Let me see if I can advance this. I have no financial disclosure. Again, the objective today is to show you some of the impacts of hearing loss on your general health, discuss the different types of hearing loss that you may experience, and also to briefly go over the evaluation and treatment options a patient with hearing loss may face. Hearing loss is actually the third most common medical disorder in the United States. This is after heart disease and arthritis. However, hearing loss does not get nearly as much attention as the other two diseases, and we are hopefully able to bring more information to you today. If you have any hearing loss, you are not alone. There are over 38 million Americans aged 12 years and older that are affected by hearing loss. And hearing loss is more common with age. So in people over 60s, at least 1 in 4 people are affected by some sort of hearing loss. So if you have any hearing loss at all, you are not alone. The number one impact of any hearing loss is that it takes away the joy of social interaction you may have with your family, and your friends. A lot of patients report that they have trouble understanding other people. They may get frustrated or easily distracted when there's any noise in the background, especially in restaurants or the family gathering. Particularly when people have high frequency hearing loss, they have trouble hearing women and children, especially those in the younger age. They also have family members complaining that that you may be watching TV too loudly, or that you may be talking too loudly. And when people have trouble switching ears on the phone or have trouble hearing the phone, those are some of the symptoms that one may be experiencing hearing loss. So it really takes away the joy of social interaction because you're constantly struggling to hear other people, especially in social environments. And patients with hearing loss commonly feel physically or mentally fatigued during conversations or at social events, particularly parties with a lot of people. And the impact of hearing loss is that they may have a sense of isolation and loneliness, which is quite important in our general overall health. When we think about the impact of hearing loss, is that when you have any sort of hearing loss and you have to do other things, such as having a conversation or trying to remember what you were doing, it's difficult. If I can explain the concept in the concept of cognitive load, imagine if you're multitasking, trying to do math and trying to do speed walk at the same time. If you're multitasking, it's become harder and slower and more tiresome, and people are prone to mistakes when they have to do math and speed walk at the same time. In a patient with hearing loss, the same concept of cognitive low applies. So in a normal, if I can show you the normal hearing patient, if you can imagine that you have maybe 6 coins, that's your available cognitive resources. You allocate 3 of those coins to tasks such as memory, remembering what you were doing, remembering the events of the day, and you allocate 3 coins to understand speech when you have normal hearing. In a hearing impaired patient, those cognitive resources are reorganized. You have to spend more effort listening. So you may spend 5 coins trying to listen in a difficult situation. And so you have less coin for other cognitive tasks, such as memory issues. So in a hearing loss patient, we do know that they may develop symptoms such as, I can't remember what I was doing. I am not as sharp as I used to be. Some of those memory issues is due to the fact that you have to reallocate the resources in your brain to spend more effort in listening. Another impact of hearing loss we know is that the part of your brain that is utilized for hearing is also utilized for memory. This is called the temporal lobe, located in this area. When you have hearing loss, other parts of the brain has to be activated in order to compensate for the fact that you're no longer hearing very well. So there is a loss of brain function in the temporal lobe. It's closely related to memory as well. In patients with aging as well as hearing loss, we do see on MRI scans or images of the brain that the brain reorganizes and the brain atrophies, meaning that it shrinks a little bit with aging as well as hearing loss. So we do know that hearing loss has an impact on the brain down the path. We also have been able to show in studies of patients who participate in longitudinal studies at the National Health and Nutritional Examination Survey that people with hearing loss are less physically active and they're less likely to seek medical treatment because they find conversations or telephone calls to the medical facilities difficult. So you do see on this graph that, compared to the normal hearing, which is a dark blue, that people with hearing loss are less active and less likely to seek activities that maintain their general overall health. This is very important to keep in mind. So of all those 3 things taken together, the cognitive low, the loss of brain function and atrophy, and a change in the health maintenance habits, we do see there is a trend for patients with hearing loss to manifest earlier signs of cognitive decline. So it's very simply, symptoms of cognitive decline may shown as, patients may say, I'm not as sharp or as quick as before, or I can't remember as well as it used to be. That does not mean that you will develop dementia. Not everybody with a little bit of cognitive decline would go on to develop dementia. Dementia is defined as when the cognitive decline interferes with independent daily activity. They cannot remember that they turn on the stove is no longer safe for them to cook alone at home, or turn on the water in the sink and they forget the water is on and they're no longer safe to take a bath or take a shower at home. That's when dementia sets in. The impact of hearing loss on the continuum between cognitive decline and dementia is an area of active research and study. You may have heard this study in the newspaper or somewhere online before, that a 2011 study has been able to show that hearing loss is correlated with increased risk of dementia when the hearing loss is untreated. This was a study based in Baltimore at Johns Hopkins Hospital. It's called the Baltimore Longitudinal Study of Aging. They followed 639 adults over 12 years. The group of patients were aged 36 to 90, and they found an overall rate of dementia, which was 58 cases, to be 9%. This is comparable to the overall population. And they've found that any hearing loss is correlated with increased risk of dementia. So I don't mean to scare you, but the statistics is quite alarming. And since 2011, a large number of resources and funding has gone into research to determine why or how is hearing loss related to dementia and how can we stop it. In order to understand why hearing loss is closely correlated with the increased risk of dementia, you first must look at the overlap between hearing loss and dementia. So in patients who have hearing loss, they may have trouble carrying out different cognitive tasks, such as remembering items, trying to recall what was told to them. And that is difficult to study because a lot of the cognitive testings that we have available require the patient to have good hearing. So a lot of the studies that were previously published probably have overdiagnosed dementia due to the fact that the study participants have a significant amount of hearing loss. And the other aspect of the overlap between hearing loss and dementia is that a lot of the cognitive decline symptoms, such as, oh, Mr. John just did not hear me very well. Probably he heard me wrong because his hearing isn't good. Or Mr. John forgot that he was supposed to pick up his medicine today because he didn't hear me very well. A lot of the cognitive decline symptoms are chalked up as hearing loss. We now know that when they are able to be fitted with hearing aids, some of those overlap can be decreased. And now with newer research, we are able to delineate better what is the correlation between hearing loss and dementia. And so we now know that hearing loss is considered by the World Health Organization a modifiable risk factor for dementia, meaning that in order to stop or slow the progression to dementia, hearing loss is something that we can treat and should treat. And to give you a general concept is that there are other risk factors for dementia, such as hypertension, smoking, obesity, diabetes, excessive alcohol drinking. Those are all other risk factors for dementia. And we have active and ongoing recommended treatment modalities for those diseases. However, hearing loss remains one of those underappreciated and underdiagnosed problems that is closely related to cognitive decline and dementia. And the holy grail of my research and a lot of the hearing researchers is that can hearing aids or any sort of hearing rehabilitation prevent or delay the onset of dementia? The unfortunate answer is that the study is ongoing. We have clinical trials. Currently, the biggest one is called the ACHIEVE clinical trial that's ongoing for 3 years, looking at over 1,000 adults in the age range of 70, 80s, looking at people with mild to moderate hearing loss, and evaluating whether hearing aids versus no treatment can prevent and delay dementia. The study is anticipated to finish in 2023. So we don't have a very clear answer, but our hypothesis is that yes, hearing loss may have an impact in preventing or delaying the onset of dementia. So the verdict is still out, but we're hoping the research may support that. Other things you may find when you have hearing loss or when one has hearing loss is that balance issues. Why do people have balance issue when their hearing has been impacted? Number one is, like I said, they're easily distracted in noisy environments because they're trying harder to listen to other people talking to them. And the brain has to work that much harder in order to process sound. So there's less cognitive resources allocated to receiving and processing balance issues. That's why people with hearing loss often have walking problems or have frequent falls, or they feel less balanced overall. So that is an important consideration in treating hearing loss. Another aspect, quite important, is people with hearing loss have tinnitus. Over 90% of people with tinnitus have some sort of hearing loss, whether it's mild, moderate, or severe. This can become quite disturbing to their sleep. People with tinnitus find it difficult to concentrate, and in severe cases can become significant psychosocial stresses to the patient. So treating hearing loss is also important in terms of treating tinnitus. We will go over treatment options a little bit later during the presentation. Other aspects of hearing loss that you may have heard or commonly found is that hearing loss is closely associated with other diseases in our body, such as cardiovascular disease. We see an increased number of patients with low frequency hearing loss at our risk of heart attacks and heart diseases. Hypertension has been known to accelerate the level of hearing loss in adults. Smoking is particularly prevalent for people with hearing loss. People with hearing loss commonly have diabetes as well. and obesity is increased in patients with hearing loss as well. So you see that hearing health is closely connected to your overall health in other aspects. In order to understand what we do about hearing loss, I must first present to you how does normal hearing work. So this is a diagram of an ear. This is the outside of the ear that you can see, touch, and feel. This is the ear canal that leads to the eardrum. The tympanic membrane is a thin piece of membrane that transduces sound from outside in, moves three little bones in the middle ear space in order to transduce sound to the inner ear, which is the cochlea. The cochlea is also sitting next to your balance organ, and all of that information has to be sent to the brain by the cochlear nerve, which is the hearing nerve, and the balance nerve, which is the vestibular nerve. And the signal goes up to the brain and processed in different ways in order for people to understand sound and understand speech. When you have hearing loss, there are three main types of hearing loss. A conductive hearing loss affects the outer ear, which is in green, or the middle ear space. And when we talk about sensory neural hearing loss, you may have commonly heard a nerve loss affects inner ear, whether it's in the cochlea and the nerve or up in the brain. So there are three areas you can affect the hearing. And when we talk about mixed hearing loss, is when the patients can have a combination of conductive and sensory neural hearing loss. And what you do about the hearing loss really depends on where the problem is. So some very common reasons for a patient to have conductive hearing loss is an occlusion or something blocking the sound from going in the outer ear. Wax buildup is a very common reason for a patient to have some hearing loss, and we do clean that out for a lot of patients, and your primary care also can clean that out. We see foreign bodies a lot, either in children with a bead in the ear canal, or actually in patients with hearing aids. Some of the hearing aid inserts can be lodged in there as well. And rarely there could be a tumor in the outer ear affecting the hearing as well. That's quite rare. In the middle ear space, the reasons for hearing loss in the middle ear space may be due to an infection. And this is a diagram of a fluid and infection in the middle ear space, preventing sound from going in. So that is either treated by antibiotics or draining of that fluid. When patients have injury to the drum or infection that has eaten away the eardrum, there may be an eardrum perforation, which also affects the hearing. Cholesteatoma refers to a skin cyst collection, as you can see here, basically a collection of skin that grows out of control, affecting the hearing as well as the middle ear space. And otosclerosis is a type of hearing loss affecting the three little bones, the last bone in there. Think about people who have arthritis. The third bone doesn't move very well, thus the sound isn't conducted in. And those can be treated with surgery to replace that third bone of hearing. When we talk about nerve hearing loss, in the red part, sensory neural hearing loss affects the inner ear. Some of the things that can give a person sensory neural hearing loss, including aging. We all lose a little bit of hearing as we go through life. Noise exposure is a significant factor in development of sensory neural hearing loss down the road. We'll talk a little bit more about that as well. Head trauma, significant car accidents, significant concussions also increase the risk of having sensory neural hearing loss. And a large part of it is genetics. Some patients are more prone to develop sensory neural hearing loss than others. And the genetics are obviously an active part of research for us. And all of those things, aging, noise, trauma, and genetics, are cumulative. And when we have cumulative damages in the inner ear, and unfortunately those cannot be undone. So the inner ears contain hair cells that normally look like a nicely spaced soldiers. When they are damaged, they become disarrayed. And now you can see, as you can see, a picture of the cochlea on the inside. When it's damaged, we unfortunately cannot restore the sensory neural hearing. And what to do about the hearing also depends on what you find. And it's important to have a medical evaluation for hearing loss. We generally perform a full history examination, which include examining the ear with an otoscopy, which is a little light to look into the ear, or under the microscope. Commonly in my office, we will examine the eardrum and ear canal and shine light into the middle ear space to elucidate if there's any disease going on. Your physician may order an imaging such as CT or MRI to determine what kind of hearing loss you had. If there's any reason to think that the hearing loss may be correctable or reversible, I think that's important to identify before you decide on the treatment options. And the treatment options on the hearing loss also depends on the extent or severity of your hearing loss. A lot of phone apps nowadays are available for people to test your hearing at home. Obviously, those are rudimentary testing results, can tell you some information, and the more advanced part of the hearing test you can also get at Costco. You know, there are hearing aid centers at Costco. There are audiologists, audiology technicians, or hearing aid dispensers. They're trained technicians to test the hearing and give you some information also fit with the hearing aids. And a properly done audiogram is in a sound booth, in a quiet booth with a trained audiologist who have spent 4 years in school to obtain an AUD or PhD degree in order to understand the full spectrum of hearing. So they may test you in a variety of ways, including the beeping of sound, understand words, or even full sentences when it comes to more complex hearing exams. So those are different options of hearing exams. I think for proper hearing evaluation, obviously the AUD and PhD level evaluation gives you more detail and gives the treating physician more detail as well. And if you have, I'm not sure how many people have seen an audiogram before, if you have ever had a hearing test, this is what an audiogram looks like. So on the left-hand side, you can see there the scale from 0 to 120 is in decibels. It's a threshold with which you need to hear. So how loud does the sound have to be in order for you to hear? 0 is the best, 120 is the worst. And up to 25 is normal. So in the blue box is considered normal hearing. The lower in the box, the worse you're hearing. And then across the frequencies up top, you can see going to 250 to 8,000 is how high the pitches of the sound. Think of the piano keys. On the left-hand side, low pitches, boom, boom, boom. On the right-hand side, high pitches, boom, 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 really high pitches. In conversation, we actually speak between 500 and 3,000. So in the yellow box is the speech range. The lower box and the higher frequencies are, obviously for music and other tones. And for this particular patient, he happened to have relatively good hearing within the speech range, but he'd certainly have moderate to severe amount of hearing loss and high frequency. And this patient is actually interesting because so the right ear are the circles and the left ear are the X's. So both ears, even though he feels like he's doing quite well during conversation, we do know that on audiogram, some of those hearing losses can be seen because the high frequency does not play into normal conversation. So this patient may not have had noticed a significant difficulty in conversation. And in terms of what can you expect in terms of level of hearing difficulties, that when you have normal hearing up above 25, conversation should be no problem. Normal conversation should be about 35 to 40 decibels in this range. The dog barking may be in the 60s, 70s range. A lawnmower is much higher at 100 decibels, and a jet engine, at 120 decibels. So depending on how severe the hearing losses are, those are some of the familiar sounds you may have, give you a concept of how loud those sounds are. And in contrast, this patient has more hearing loss. So at this level, let's go back. At this level, this patient has mild to moderate amount of hearing loss in the right ear and moderate to severe amount of hearing loss in the left ear. So this patient is missing about 50% of the conversation. And so this patient is definitely coming in to my office with more subjective difficulties in terms of hearing. What you do about hearing, it really depends on the severity, and usually at counsel, my patients, it really depends on how much you struggle. However, an important concept to keep in mind is that there's a big difference in the way, unfortunately, we treat patients who are pediatric, who are children versus adults. In children, everything is covered. If you have any hearing loss, we highly recommend hearing aids. Hearing aids are covered in children. Unfortunately, for adults, because hearing aids are not covered, we end up taking a less active approach. But hopefully this seminar is to show you that that I think we should take a more active approach to treating anybody with hearing loss. So in terms of big categories of treatment options, observation is always an option when patients have had some hearing loss, but they can't be bothered with hearing aids. Observation is an option, but we will go into some of the tips we have for you. Hearing aids, we will go into a bit more about hearing aids in a few minutes, and surgery, when we are able to identify a correctable or reversible form of hearing loss, surgery is generally offered. When observation, hearing aids, and surgeries have failed, there are implantable devices that we offer, but we will mention them very briefly today. A main take-home point, hopefully you get from this webinar, is that no matter what you do with your hearing, it's very important to stay active, that to pay attention to your general health. And I think hearing loss really does impact on how active the patient can be, and really impact on their general health by not paying attention to that aspect. Some of the tips I have for improving your communication when you're living with hearing loss is that, number one, it is a very common condition. You're not alone, so certainly do encourage you to tell people, especially people you love, people you communicate often about your hearing loss, that, hey, I have a little bit of hearing loss, please talk to me directly, please enunciate, please speak up when you need to talk to me. So that's very important for you to tell people when you're living with hearing loss. Also, I do hear that commonly with my patient is that, the spouse may say, he just can't hear me if I'm yelling at him from the kitchen. Well, the number one tip is really tell the spouse, please come talk to me in the kitchen if you need my attention. Otherwise, if I don't hear you very well, that communication may be mistaken. I encourage patients to face the person who's talking to you directly, either at a meeting, at a party. And also, one very simple thing is to sit with the wall behind you, either at a restaurant, at a meeting. When the wall is blocking the noise from hitting you from the back, it really significantly increases the signal to noise ratio when you can have the target right in front of you. So that's a very simple thing to do by sitting with the wall behind you if you have that choice. And also, a lot of the communication can be mistaken when you're having hearing loss. A lot of the mistakes, a lot of frustrations occur when the misinformation is mistaken. So I encourage you to rephrase information, especially in a very particularly important conversation with your spouse, family, or at work. Another thing about observation is that we don't commonly hear about hearing protection until it's too late. Noise exposure is incredibly important. And we have neglected that for many, many years. So an example is that at the football stadiums, you certainly start to see some of the football stars, even Michael Phelps at the Olympics, when the babies go into the arena, the sporting events as loud as 100 decibels can cause damage within, 15 minutes. And any sound over 85 decibels is known to cause damage. So by OSHA regulation, by the government regulation, if you're working at the airport and you're exposed to noise over 85 decibels, you are required to wear hearing protection. But we don't do that when you're blowing the leaf or mowing the lawn or going to a rock concert. So a lot of the younger generation, we're trying really hard to tell them, please protect your hearing when you're going to all those things, rock concerts or sporting events, because noise exposure is cumulative, and it will not show up until 10, 20, or 30 years later. Head trauma is increasingly significant. We see that with the concussion studies. We see that with motor vehicle accidents. And we also generally trying to talk to patients about identifying some medications that are bad or ototoxic to the inner ear. Some of the necessary medications, but they're ototoxic, include chemotherapy. So we are working closely with any patient who have had exposure to chemotherapy for cancer treatment. So those are important things to keep in mind in order to protect your hearing down the road. Noise is very important, head trauma, and medications. When it comes to hearing aids, the problem with hearing aids, it is a very good form of treatment for hearing loss. It's the least invasive. However, it is not covered by a lot of insurances. When people do decide to get hearing aids, it's like buying a computer. There's a wide range of size and capabilities. A lot of my patients ask me, what is the best kind of hearing aid? There's no good answer for that. It really is up to your lifestyle, and it's important for the audiologist, the hearing aid dispensers, or the audiologist to show you the different kinds. I would advise to say that try different ones. You can return them if you don't like it within the warranty. That you have to find the one that's best fit to your lifestyle, to your hearing. And the expectation is very important to set the expectation right, because unlike glasses, I use the eyeglasses analogy for a lot of my patients. Unlike the glasses, when you put it on, is instantaneously clear. The hearing aids, unfortunately, the technology isn't all that, is not like the glasses where you put it on, is instantaneously clear. It is still a digital device, and it sounds a little bit compressed or different from your normal sound, and people can get frustrated if that expectation is not set right. And there's a wide range of prices and capabilities of hearing aids, and the analogy is also similar to the glasses. You do have the ones that are over the counter. Imagine if you walk into CVS, there are glasses that are available as well. There are over the counter amplifier or hearing aids you can buy on Amazon or at Costco. Can they do very well for patients who have mild hearing loss? Absolutely. If you just need a little bit of sound, it needs a little bit of help with hearing to TV or something, the TV ears or amplifiers are very appropriate. When your hearing loss becomes more severe or have more complicated shape of your hearing loss, that's when you need a prescription strength hearing aid, similar to the prescription strength eyeglasses that are fitted to you. If you and I, or you and your spouse or your partner were to trade glasses, it probably doesn't work very well. It's very similar for the hearing aids. If my hearing aids were used on you, probably doesn't work very well. And the importance of a medical evaluation is also similar in glasses. It's important for the ophthalmologist or ophthalmologist to check your eyes to make sure we're not missing any correctable or reversible form of disease that may be causing a problem. So very similar for the hearing aids. And I hear a lot of frustration from my patients that hearing aids cost a fortune. We as providers, as physicians, are equally frustrated by their cost too. It's unfortunate that it's not covered by a lot of insurances, but we have ongoing clinical trials basically trying to prove to the insurance company and the government that there are huge benefits of hearing aids. And there are huge benefits in terms of treating hearing loss. So the result of that is a 2019 government policy change called the Over-the-Counter Hearing Aid Act. So starting this year, you are able to get some hearing aids over the counter. This is really trying to incentivize some companies, especially large tech companies like Apple, to innovate and get involved in selling hearing aid technology so that it can become cheaper for the general population. And also to allow us to advocate for Medicare to cover hearing aid related services as well. So changes are coming. Unfortunately, they're happening very slow, but we know that a lot of our patients with hearing loss are very frustrated by the cost of hearing aids. I just want to let you know that we are equally frustrated, and we as physicians involved in the hearing aid, involving the hearing health research, we are trying to push to change that. And a little bit more about surgery. There are a few forms of correctable or reversible treatment options for hearing changes. It involves removing the fluid, repairing the eardrum, removing the cholestoma, and very rarely removing the tumor involved in the ear. And then we have little prostheses that can restore that. But again, those are depending on what the medical evaluation occurs. And when patients are frustrated or hearing aids are no longer enough, when hearing aids, no matter how powerful they are, have reached benefits, cochlear implants are available for people with severe to profound level of hearing loss. And there is a huge evaluation process to determine if one can meet criteria and gain benefit from cochlear implants. They are available for pediatric and adult patients. And in patients with severe to profound hearing loss, cochlear implant has been shown to improve attention, span processing speed, working memory, and there are ongoing longitudinal studies to study the impact of cochlear implant in preventing and delaying dementia as well. So that's something on the horizon. And a little bit more about tinnitus. Tinnitus, a lot of patients coming, seeing me or my partners about tinnitus. It really depends on the severity of tinnitus that we decide what form of treatment you decide to pursue. And to understand tinnitus, it really is a phantom phenomenon. So similar, the reason I have a picture of a veteran here is, I don't know if you ever heard of phantom pain. In soldiers who lost their arm or leg in the war, they actually continue to have pain in that leg. Is because the brain is telling you that the signal from the leg is missing. So it actually fills that void with a pain sensation, even though the leg is gone, is due to the signal coming from the leg being disrupted. Very similar understanding we have of the tinnitus is that it's a phantom phenomenon coming from the brain. When the signal of the hearing or the hearing loss has occurred, the brain can tell you that, hey, there is something different about the hearing signals. So we know that people who have hearing loss can have a significant tinnitus due to the fact that the worse you're hearing, the worse the tinnitus. And the most important treatment is actually white noise, background noise, distracting your brain from listening to the tinnitus and distracting the brain so it has something else to focus on. That's actually, if you have ever talked to anybody with significant tinnitus, they actually found that the simplest thing to do is turn on the music or turn on a fan that is in the background, and it reduces their awareness of the tinnitus. And a very large part of the treatment is about reducing the stress and anxiety surrounding tinnitus and removing any medication that may worsen tinnitus. Other forms such as hearing aids can be helpful when people have a significant amount of hearing loss, that the hearing aids can be helpful for the tinnitus. There's $1 billion industry out there selling supplements for a cure for tinnitus. Unfortunately, nothing has been proven to be 100% effective. There are also interesting tinnitus apps people have developed for the phone, either for iPhone or Android, to find the frequency for the tinnitus that plays pleasant sounds specifically tuned into your tinnitus, and people, especially my patients, may have found that helpful. In severe cases, cognitive behavioral therapy with either a psychologist or psychiatrist can be helpful to reduce, again, the stress and anxiety surrounding tinnitus as well. So overall, hopefully we have been able to show you today that hearing loss can contribute to multiple hearing conditions, and that the overall health maintenance, especially treating other diseases such as cardiovascular disease, obesity, diabetes, and cognitive decline, are important for your hearing health as well. And the goal of any hearing treatment, obviously, is to help you hear better, and it's to stay active and pay attention to your overall health. So, if I can summarize in one sentence, is that your total body health is closely related to your hearing health, and hopefully you're able to pay attention, address both. So now we have some time. I would like to take questions. So I would see if Marsha can read some of the questions. I think we have plenty of time for questions today.
Yeah, we do. We have a lot of great questions. Let's see. One of the questions that came in was, are other drugs and chemical solvents also major causes of sensorineural hearing loss? Like, what are some of the other things that are causing?
Right. There are a long list of potential medications, especially at high doses, that are toxic or damaging to the inner ear. So one very, very common one, and I don't want you to freak out. So Tylenol or acetaminophen at very high doses are toxic to the inner ear, but we're talking about, drug overdose on Tylenol. So if you're taking Tylenol for garden variety back pain, once a day or even 3 or 4 times a day, are not bad for your hearing. But when you have ringing, I generally recommend that if you can take it, alternating with ibuprofen is probably more ideal. Other medications, such as certain forms of antibiotics like vancomycin, aminoglycosides, gentamicin, tobramycin, those are strong antibiotics that if you happen to have required it for a severe infection, those may affect the hearing. And the largest group of medication that we know are toxic to the inner ear that are better studied are the carboplatin or cisplatin. Those are chemotherapeutic drugs for cancer. So hopefully that answered your question.
Okay, thank you. Some people ask about tinnitus. Does it have the same impact on your health, like the dementia and the balance and things like that, that you mentioned that hearing loss does?
Yeah, the problem with tinnitus is that it's a very subjective experience. So for hearing loss, we can, in order to study something, you actually need to quantify. So for hearing loss, we are able to quantify on a hearing test, whether it's mild, moderate, severe, or profound. The problem with the tinnitus is that no matter how mild or how severe your hearing loss, whether your tinnitus bothers you, the extent of the severity of your tinnitus is unfortunately very subjective. So those studies have been very complicated and unfortunately have not been done very well. So I would say I think my screen stopped sharing, but that's probably fine, right, Marcia? So
Yeah.
Unfortunately, the correlation, the impact of tinnitus on your general health is probably not very well understood.
Okay. Someone asked, based on the audiogram slide that you have, normal hearing was on the right and the out of range hearing was on the left. Can you kind of explain that a little bit more about how that information is used?
So should I go back to share the screen, I guess?
You could, yeah.
Yeah, let's see.
Let me.
Let's see if we can go back. So for this patient, this is just a general audiogram of equivalent of how loud the sound has to be, right? So this patient has right here, which are the circles, has hearing, up to 25 is normal. So up in this range is normal. This patient has mild to moderate amount of hearing loss, meaning that with the right ear, he or she may be missing a normal conversation about 40 or 50% of the time. And this on the left ear alone, it's more moderate to severe. So, without any hearing amplification, they may be missing more of the conversation because normal conversation is occurring at 35 to 40 decibels. Does that make sense?
Mm-hmm. Yeah. It's interesting. It's interesting that it looks like that. It feels like it would be much more high tech than that. Someone wants to know, why didn't my audiologist test my hearing back in the booth when I got my hearing aids back in place to show me how much better I was hearing now? With mild to moderate hearing loss, it's kind of hard to perceive how much things have really improved.
Right. So for a full audiogram test with the hearing aid, that's actually going to more evaluation. So most of the audiologists do not retest you with the hearing aids. What they try to test you is see if you're comfortable with the sound level that the hearing aids are introduced. They don't necessarily test you with the words or sentences, which is one of the limitations of an audiology visit. But when we go into, say, a cochlear implant evaluation or a more in-depth speech evaluation, that's when they test whether the hearing aids are adequately fitted to your hearing loss.
Okay. Someone had a question about what's really considered a very high dose of Tylenol.
Over 3,000 milligrams. So in a day or at a single dose. So if you're taking 500 milligrams, you can take it many times that one day, but over 3,000 milligrams is considered a high dose of Tylenol. Okay. Assuming you're not popping a lot of them at one time.
Someone also wanted to know, where can they find any data on chemotherapy and how that affects hearing? What would they maybe search online for that?
And you probably will search. So if you have a particular medication, in mind, you actually can just Google it. A lot of medications are listed on a prescription. It's called RX data. You may find that whether the medication has any side effects on hearing loss. And if you're looking for a whole list of hearing loss medications, there's a huge list. So I would recommend that you may talk to your prescriber, either your general practitioner or whoever prescribed that medication, about the potential impact of that medication on your hearing.
Okay. And would your pharmacist maybe have information about that too?
Sure, but probably a pharmacy would have information most likely regarding the higher doses. So, usually you're probably not going to have any trouble, for example, with Tylenol. The pharmacy is not going to tell you, oh, don't take Tylenol because you may potentially have hearing loss. We're not talking about everybody taking Tylenol getting hearing loss.
Okay. And I know you covered this in your talk, but can you tell us a little bit more about what causes tinnitus?
Again, it's a brain phenomenon. So usually the brain's way of telling you the hearing isn't the same. So why the brain can tell you that is actually quite interesting to research, but we know that basically is brain's way of telling you the signal from the ear or from the hearing organs are not the same. And a lot of patients can have worsening of the ringing of the tinnitus. It could be ringing, whooshing. Everybody's tinnitus is different. It could be multiple frequencies. That when the brain goes into overdrive, either with stress, anxiety, or with medication, the ringing can become worse. We do see patients when they go through a stressful event that the tinnitus gets worse, or when they go through a bout of illness, tinnitus gets worse. And patients who can also have tinnitus worsen for no apparent reason. It's sort of just brain's way of telling you the hearing has changed.
Okay. Someone asked a question that said, my tinnitus became constant when I was pregnant, actually, and hasn't gotten any better in over 20 years. I've had my hearing tested, and I have mild hearing loss. My audiologist recently encouraged me to get hearing aids, but I fear that a worsening hearing loss is going to be affected by this tinnitus. Is that a concern?
No, usually your hearing aid should not affect the progression of your hearing loss. And unfortunately, when you're living with constant tinnitus, you probably have seen many people that there is the hearing aids are helpful, but nothing really takes it away. Unfortunately, what we try to do is tune it down and try to make it less noticeable. And the hearing aids can certainly do that for you.
Okay.
To make it less noticeable, and so it makes conversation perhaps a bit easier.
Okay. Another great question about tinnitus. Some audiologists are just trained in hearing loss. How do I know if my audiologist is tinnitus certified? Is there a certification process they must attend? And is the hearing test different if you have tinnitus?
No, I would say that there is not a special certification to treat or evaluate tinnitus. There are hearing aid audiologists, especially the AUD and PhD level ones, that they can program the hearing aid with a tinnitus program in there. So for a patient living with hearing loss and tinnitus, the audiologist depends on the level of training. It's hard to say, walking into an audiology office, obviously the ones with a university are all trained to do that, is that they can program your hearing aid to have a masking sound at the level of your tinnitus to see if that would be helpful when you're living with hearing loss and tinnitus. But there's not a certification or specialization in tinnitus. There are some audiologists who are better at it than others. But again, there's not a specialization.
Okay. Are there any supplements or any other things like caffeine that aggravate tinnitus?
Yes, a lot of things we know makes tinnitus worse. So caffeine certainly makes it worse. Anything that makes the brain go into overdrive worsens it. So a lot of caffeine. Some patients, when they, some of my younger patients take Adderall, any brain stimulant makes it worse. We do know that pain medication, controlled narcotic pain medication, for whatever reason, makes ringing worse as well. And again, high doses, when patients are in chronic pain, they take high doses of either narcotics alternating with Tylenol or Motrin. Those can be worsened for tinnitus as well.
Okay. Someone asked, if the brain adjusts as a consequence of hearing loss, would the brain just adjust with prolonged use of hearing aids, as in like retraining your brain?
Yes, we do actually have studies, very interesting studies, This is more in the arena of severe to profound hearing loss because we don't really have a large, so then, the ongoing study with the mild to moderate hearing loss patients are limited, but in the severe to profound level of hearing loss, we do know that those patients are able to demonstrate reorganization of their brain. It's called functional MRI. So, MRI is usually a black and white picture of the brain at a one time frame. When you're talking about functional MRI studies, is when we can study the activity or the connection of the brain in real time. And we are able to show that with severe to profound hearing loss, when you reintroduce hearing, either with hearing aids or cochlear implant, that patient are able to reorganize that brain and reconnect the temporal lobe to different areas of the brain. So that's a very interesting ongoing study. But again, we do those studies in severe to profound level hearing loss patients first.
Okay. You might want to stop sharing your screen so they can see us a little bit.
Oh yeah, sure.
Someone asked a question. Are there any clinical trials for patients with Meniere's disease?
Yes, there are many Meniere's patients, clinical trials, and depending on the treating physician and depending on the patient's symptoms, when you think about Meniere's patients, you think about fluctuating hearing loss, tinnitus, fullness in the ears, and dizziness, right? Vertigo, room spinning vertigo. So there are ongoing clinical trials, and I think we would encourage you to talk to your ENT or your treating physician about enrolling in them and different medications. I'm sure any Meniere's patient can tell you that Meniere's is difficult to treat. It goes into remission and it sort of spontaneously can flare up as well. So depending on where they catch you in terms of your treatment, patients spontaneous may go through months without a flare up, or they can have flare up for months at a time, which is debilitating. So there are certainly interesting clinical trials for Meniere's disease.
Okay. We have a question. Sometimes I have itching in my ear as though a bug or a hair is loose in the canal. What's that all about? And what can I do about that?
We see that very common. Obviously, it really depends on your ear exam. We would first need to make sure there's no hair or bug in the ear canal, but usually Q-tip use is a very, very huge common culprit. So if you are itching in the ear, stop using the Q-tip. It makes the skin very irritated. It's actually good to have a little bit of wax. So imagine that the wax is your brain, your body's natural way of protecting your skin, preventing infection, and preventing any bacteria from overgrowing. In a chronic Q-tip user, I want to know if this question was asked by somebody who uses Q-tips or not, because usually when you're cleaning in there very frequently with Q-tip, it takes away all the wax. It's very irritating the skin, and it probably feels like there's a bug crawling in there because the skin is itching. So there are different things to try, but very important to make sure you're definitely not having a bug in there, number one. Number two, stop using the Q-tip.
But they feel so good.
But imagine, your body, humans have been able to self-clean, the ears are self-cleaning for millions of years before Q-tips were invented. So we've been doing well without Q-tips.
Okay. What about every other day? Let's say every other day. Okay.
We see a lot of Q-tip injuries in my office. I would not want to see you in my office for Q-tip injury.
Someone says, I can hear my pulse constantly in my left ear. Is there anything that can be done for this?
It also depends. So it depends on what, obviously when you come into the office, we need to make sure there's no fluid, nothing bad, depending on whether you have had injury to that area, if there's any trauma, or any asymmetric hearing loss, that we may end up having a CT scan or MRI to determine if there's any vessel either having issues, and there are correctable or surgically corrected cases of pulsatile tinnitus, hearing your own pulse. And to answer the question, it's a very long answer, but it really depends on what we find on exam and also on the imaging studies.
Okay. Someone asked a question. Are there any potential medications for regeneration of the hair cells that currently exist or are in trials?
Yes, there are many studies are different ways of introducing not so much medication, but vectors into the inner ear. So the inner ear, actually the anatomy is very, very interesting. This is coming from an ear nerd, or I'm like huge ear nerd. Hopefully you're an ear nerd since you're attending this webinar. But the inner ear is actually a protected space, meaning that the cochlea is completely isolated, except it communicates with the inner ear, with the brain fluid, that it's encased in a hard bone. So in order to deliver some of the things to regenerate hair cell has been difficult. But in animal studies, we've been able to regenerate the hair cell either with virus or stem cells. So hair cell regeneration in order to restore hearing is on the horizon, but in humans, those are limited to children or people with congenital hearing issues that the hair cells already gone, that in order to regenerate, you would deliver the vector, either a virus or a stem cell population through a quite traumatic procedure. So animal studies have been very successful. Again, humans have been limited due to how hard the bone is and how invasive the procedure will be so far.
Okay. So we had a question. Where do I find help with finding the right hearing aid? I was diagnosed with, I'm gonna say it wrong, osteosclerosis.
Otosclerosis.
Yes, okay.
Yes.
And then I feel like that was in my left ear after that. My left ear was left on its own after that.
Okay, so depending on the severity of your hearing loss, otosclerosis is considered a treatable and reversible form of hearing loss. So hearing aids are very good options. The hearing aid audiologist should be able to fit a hearing aid that's comfortable for you, loud enough for you. You know, I would certainly look for an AUD, but because by the time you have otosclerosis, the hearing loss may be a bit more complicated to fit. So an AUD or PhD audiologist, obviously we're going to plug into the UF system here. We have very good ones at UF. And the other thing is for otosclerosis, you know, surgical treatment is considered an option when it's severe enough.
Okay, so this person and several others also mentioned yeah, I know I have this, I know I need this, but how do I afford this? Is there any help? Are there options? I know that
for the hearing aids or for the
hearing aids, yeah.
Yes. So there are some, you know, depending on the insurance, you may call your insurance company to see if they cover some, you know, depending on the insurance, some covers, you know, maybe like $1,000, but most of the hearing aids are not covered. Obviously surgery is covered because it's a surgical procedure.
Okay. Okay, a lot of questions regarding this. I've worn many different types of hearing aids. I've also had a stapedectomy with a 10%.
Stapedectomy, yeah.
I'm still frustrated. What's your advice?
It probably is a pretty lengthy discussion depending on what your hearing test looks like.
Okay.
So especially if you're frustrated with your hearing aids and you've had surgery before, it's important to know what the audiogram looks like in order to probably give you more individualized advice.
Okay. You also mentioned cochlear implants. We didn't talk much about that, but with cochlear implants, what about post-implant therapies and mapping? What do we have here at UF Health?
Absolutely. So cochlear implant, you know, no matter where you go, you want a whole team. A cochlear implant team involves, you know, at UF, we have 3 surgeons and a whole team of audiologists. So normally speaking with a cochlear implant, you know, especially for the interesting person who may have had a SABI surgery and then still frustrated with hearing aid, potentially may be a cochlear implant candidate. And when you become a cochlear implant candidate, we generally give you an outline of what to expect. So usually you get surgery and you get activated a month after surgery, and you are going through to the audiologist for mapping sessions the first month several times, probably every month or so, until you reach a stable platform where you feel that you're comfortable using your cochlear implant. The beauty about cochlear implant is that your brain actually learns to use it. So initially it might not sound entirely like normal hearing, but most people actually reach the maximum performance anywhere between 6 months to a year. So you work very closely with a cochlear implant audiologist who specializes in programming that for you. And we have a whole team here to program the cochlear implant for you. So this is the most comfortable and most the best condition for your listening tasks.
Okay, good to know. So that's a fascinating, advance that we've seen. Someone should we use mineral oil in our ears ever?
Absolutely. That's probably the better way of cleaning out your ear if you are worried about wax or any itching or any bug crawling. Mineral oil is all, or baby oil, anything unscented is all. I don't know if anybody's ever been in my clinic. I'll tell them the only thing you need to put into your ear, nothing smaller than the size of your elbow in your ear. Baby oil or mineral oil is all you need to help the wax coming out naturally without causing any damage to the eardrum or ear canal skin.
Okay. Someone said to remove inner ear fluid, do you do this with medications, or is it some sort of a tube that you do that with?
They're probably talking about middle ear fluid. There's definitely fluid in the inner ear space, but we don't generally try to remove it. It will be damaging to the inner ear. When you have middle ear fluid, like an infection, or we see a lot of patients after a sinus infection or upper respiratory infection, you can certainly develop fluid in the middle ear space that lingers. So I generally remove that fluid with or without a tube, depending on your history, right there in the office.
Okay. Someone asked another question about tinnitus. What is habituation from tinnitus, and will I still hear it?
So habituation is generally an idea of trying to help you cope with the fact that you're aware of it, this sound that is not generated from the inner ear. It's sort of habituating is meaning that making you less bothered or less impacted by the tinnitus. So basically it's trying to train you to listen to other sounds and calm, either slow your heart rate or keep your blood pressure low when you're having a bothersome episode with the tinnitus. You probably will still hear the tinnitus. It does not take away with habituation. It only simply, what I call it, tune down the volume and make you less annoyed by it.
Okay. Another tinnitus question. I was prescribed hearing aids due to tinnitus and high frequency hearing loss. I think my tinnitus made hearing tones in my test more difficult. I also believe my tinnitus is worsening. What should my next step be?
If your tinnitus is worsening, certainly recheck your hearing test, and it's important for the treating provider, hopefully ideally an ENT or your audiologist, to compare to show you if there's any progression of your hearing loss or not. So in any patient who have progression of tinnitus, I highly recommend to make sure that your hearing loss is A, stable, and B, if there's any asymmetry, we generally get a scan, either MRI, most likely an MRI, to make sure that we're not missing anything we can't see beyond the physical exam. If the tinnitus is worsening and depending on whether the hearing aids are helpful or not, they also can tune up the hearing aids. So meaning that make the hearing aids a bit more powerful in order to either mask the tinnitus or help with the progression of your hearing loss.
Okay. Are eustachian tubes issues and problems connected to tinnitus and hearing loss?
Eustachian tube dysfunction. So the eustachian, for those who are not familiar in the audience, eustachian tube is the ventilation. Imagine the middle ear space. The middle ear space contains the 3 bones of hearing that conduct the sound from outside in. The eustachian tube is the ventilation tubing that connects the middle ear space to the nose. So when you're having eustachian tube problem, meaning that maybe some allergies or sinus problems blocking the ventilation system to the middle ear space, you can certainly have hearing loss. Whether you definitely have tinnitus from that or not, it's difficult to say. Most of the time, eustachian tube alone probably does not cause a very significant amount of tinnitus.
Okay.
But eustachian tube dysfunction certainly can give you a little bit of hearing loss.
Can hearing aids push the wax deeper into your ear canal and maybe block your hearing aid?
Absolutely, yeah. We see that commonly, that patients who start wearing hearing aids all of a sudden have more accumulation of wax because the hearing aids are essentially, preventing the wax from coming out, especially in patients who wear the hearing aids constantly or near constantly. When they wake up, they put it on, and when they go to sleep, they take it off. Highly recommend taking off your hearing aids when you're sleeping. So you can certainly have more frequent wax buildup with hearing aids.
Okay. What about headphones that work by bone transmission rather than sound? Are they okay with the hearing loss?
Absolutely, though. So the bone conduction headphones are one of those. I recommend that to everybody. If you haven't tried it, it does deliver quite good quality of sound, and it's sort of anchored on your temporal bone here. So you can wear it and still listen to traffic, still listen to people. If you're out running or jogging, you can hear the traffic coming at you while listening to music, or you can on the headphones, you can have a listen to a webinar and still have a conversation with your spouse. So those are very good technology. We actually have very similar technology for patients. A bone anchor hearing aid or a bone anchor hearing implant utilizes the same technology. The fact that you can conduct sound basically faster in a solid medium. So the skull is a solid medium. Sound actually conducts better, travels faster and better in a solid medium than air or the hearing organ. And so when you put the sound directly on skull, you can hear that very well. We utilize some of the same technology for people who have chronic ear diseases or have, some of the kids who are born without good development of their middle ear and outer ear. We use the same technology. So those are certainly helpful. The bone anchor headphones that you can get over the counter, though, are not replacing hearing aids, because they don't actually amplify. They don't make the sound louder. They just introduce the sound from either your phone, but they don't have a microphone to detect the sound and make it louder at the level that you need. There are bone anchor hearing aids that the audiologist can dispense.
Interesting. I never heard of that. So, a question that's come up kind of is, so what's the next step? So if someone thinks they have hearing loss or tinnitus and they need more guidance, do they schedule an appointment with you, or do they schedule an appointment with audiology? Where do they begin that first step?
I think the easiest is to see an ENT with an audiologist in the same office. Here at UF, you basically walk into the ENT clinic, you basically see me or one of my partners and see the audiologist the same day. There are some offices that may be separate. There are some offices that may require you to see your primary care first, but it's very simple just to see both the ENT and the audiologist at the same time, which we do that here.
Okay. And does a person need a referral, or can they say, I think I have hearing loss, I want to schedule an appointment with Dr. Chen?
I think you should certainly call the UF Oaks to make an appointment, and the front desk can tell you whether you need a referral from the primary care or not. It depends on the insurance, but the front desk is very good. If you need a referral, they will work on that with your primary.
Okay. And I know that if you start, for instance, with audiology directly, you do need a referral for that. So I want to put in my own little plug for audiology. I've got many family members who've used their services, and they're just wonderful, wonderful to work with. And their goal is to get you, like they say, we sell all models of cars. We can get you the most deluxe one or the most basic one, and somewhere in between, and work with you on that. And
right,
really patient at coming back and turning it up a little bit more, and
yes,
adjusting those things and questions. And someone had a question for them recently, and working on a lot of different things, because it's not even just hearing aids that really help, but
right.
When your cell phone can ring in your ear now, instead of you having to put it up there and try to hope that you hear. I mean, those are big advances in what can happen. And when your TV can play in your ear now and you have hearing loss, it's really a good thing. So
when you go to the movies, it's FM streaming to your hearing aid. So that's really helpful to have those technology. But again, you can spend a fortune on hearing aids. The key thing is to return them if you don't like them, or change it.
All right. So someone just actually put in another question that says, my physician sent me to an ENT for a tinnitus workup. The ENT told me there was no tinnitus workup. How do you find the right ENT?
Generally speaking, for tinnitus, depending on the severity and which side you hear on, the workup involves a hearing test, potentially may involve a MRI of your brain, and depending on how severe your hearing loss and how severe your tinnitus are, you may try different things like white background noise, and then the hearing aids and the tinnitus apps are very helpful as well. So you're welcome to come to UF, but again, that's a general overview of any tinnitus workup. It may most likely individualized depending on your situation.
Okay. Well, that is all the questions we have for this morning. So I thank you for your time and your information. It was very informative, very helpful. And thank you everyone for joining us. Thank you.
Thank you, everyone. Have a good day.